Mixed cannulae, expanding performance standards. High-performance cannulae for direct and femoral cannulation in minimally invasive cardiac surgery. LivaNova's complete range of mixed dedicated products allow easy and reproducible procedures. The portfolio includes the sutureless aortic valve Perceval, Memo 4D for mitral valve repair, the HeartLink system for assisting the perfusionist in applying goal-directed perfusion therapy, and a broad choice of high-performance dedicated cannulae. LivaNova's range of cannulae suit every cannulation technique for minimally invasive cardiac surgery. Venous and arterial femoral cannulation can be performed using the WRAP venous cannula and the EasyFlow Duo. For arterial direct and venous femoral cannulation, the EasyFlow aortic cannula and the WRAP are available. For venous femoral access, the LivaNova WRAP cannula features a dual-stage configuration for optimal drainage of the inferior and superior vena cava without interfering with the right atrium. The high-flow dynamics of WRAP improves the capability of drainage with a low pressure drop. An optional Sellinger dilator kit is available to perform percutaneous insertion. The LivaNova EasyFlow Duo cannula is designed for a safe and smooth femoral arterial cannulation. Its conical dispersion tip design allows a more gentle flow in the femoral artery, and its red cap avoids blood backflow during obturator removal. A dilator kit for percutaneous insertion is also included with the cannula. EasyFlow cannulae are designed for safe, reproducible, direct aortic cannulation and include a malleable stylet to aid cannulation insertion, facilitating bloodless introduction into the aortic arch, as well as a special conical dispersion tip for a more gentle flow in the vessel to reduce shear stress.
The point-of-care program at Huntsville Hospital is approaching its 20-year anniversary. As we began to grow as a hospital and provide more complex services to our community, the need for point-of-care testing became very clear in our organization. Many of our departments consider the EPOC device to be crucial to their ability to quickly move their patients from entry to the hospital to procedural room. It helps them monitor the patient's status during their procedures and post-procedure, so it's very integrated into our entire continuum of patient care. If you have any patient population where blood management is crucial, then a point-of-care device is very useful in those types of settings. It can provide a quick result on a very small amount of blood, and that is really important in some of our patient population.
We are starting a new process where we're going to screen our patients on the floor for sepsis. The patient can look and actually feel okay. They will show us signs and symptoms of sepsis. So what we do when they show these signs, we get a lactate level.
Lactic acid is a product of the sepsis cascade. So with sepsis, the inflammatory light switch goes on, the cascade starts churning, and unfortunately, once it starts going, we have to stop it. It will not stop on its own. The faster the lab draw, the faster the lab results, the faster you can act on it.
The process in the lab is what the process is. It just takes a certain amount of time for the instruments to run those tests.
I mean, we're talking 30 minutes even on a stat because that's the process. That's just how long it takes. There's not really anything you can do about that. For every hour you wait to give an antibiotic, the mortality for that patient increases 8%. So now that we have the handheld device, the nurse can get those results within a few minutes, and we know how to treat that patient. If a patient is going into septic shock, we do not have minutes to spare. We have got to get it done quickly. So when you get the little beep from the EPOC that says your results are in, you go with it. You don't even think twice about it. You're like, this is good. This is what I'm going to do for this patient. The next steps are clear.
I think our mortality on the initial floors dropped by almost 50% in the first 3 to 6 months. At this point, we're about hospital-wide. I think we'll be hospital-wide another 2 to 4 months. So this has become a huge program within our system.
Without the EPOC device, it would really be hard for us to get everything done in the timely manner. So it's really helped us to get our program going.
I mean, whether you're a surgeon, whether you're a medicine doctor, whether you're a dermatologist, you want to be able to do things in a timely fashion so that you can be most effective.
This really makes a difference in patient outcomes.
And welcome everyone to PerfWeb 52, Journal Club number 14.
Correct.
That's correct. I'm here with Tammy Sparacino coming in via Skype, which you'll see later. Will be John Ingram, of course. Thank you all for being here. I appreciate it so very much. Our programs are really getting popular, and I'm enjoying the heck out of this. We really are. But we want to bring you, relevant content as well, right? It's fun and hopefully enjoyable for you, but we also really want to be relevant, right? It makes sense and have a good program and have good content for you. I have to go through all the housekeeping notes. It's mandatory. By the way, I've been up all night, so forgive me if I don't look my usual gorgeous self. I'm really sorry about that, but it's been absolutely horrible. I'll talk about that when I get through this. I know the other guys are telling me to move on. LivaNova, our sponsors, Siemens Health and Ears, and HET. For the record, we are hiring. You can go to het.us. We're hiring for perfusionists. We're hiring for autotransfusionists. And we're soon to be hiring for nurses as ECMO specialists. So keep an eye on that, okay, coming up. Check our website out. It'll have information on it. So if you know anybody that wants to move to Houston and work with a great dynamic group, wonderful people, and be involved in stuff like this, please refer them to us. Social media, make sure you check out our Facebook, our Twitter, our YouTube, our LinkedIn, and make sure that you like, follow, share, give us a thumbs up. No thumbs downs are allowed, and subscribe. That's very important. And make sure you click the bell for the notifications, the notification bell icon. Our websites, we have perfusioneducation.com and perfweb.us for reference. Perfweb.us is where we have our schedule for our live events, and perfusioneducation.com is where you can join. Membership is free. You only pay if you need CEUs, but it's a great way for you to keep track of everything you've done. So membership is free, and all of our content is free, as you well know. Approved for ABCP Category 1 CEU, and soon to be approved for more disciplines. Call-in number, when you see our notification, please feel free to call in. Very rarely does anybody ever call in. It kills me. But we used to have a few more, but the phone lines are on. Please don't be phone shy. We used to call it radio fright. Where you'd have to talk on the radio or something like that, and you click the mic and you go, and you don't know what to say. But call in on the phone and get a part of the discussion. We'd love to have you. And if you want to be let's say you want to be a faculty member, you have some great content, you'd like to share a story, I got an email from an attorney just the other day up in Minnesota who watched our program after having an acute type 1 dissection with deep hypothermic circulatory arrest and selective cerebral perfusion, and he wants to tell his story about that event and what he can remember from it. I think it'd be compelling information. It'd be very nice to hear from patients, that especially those that did well and went back to work in such a cerebrally challenging discipline like law.
Exactly.
And he's in consumer protection, I think. So it'll be interesting. He'll be coming up, I think, in April. We have our new app, of course, the critical care app for perfusionists, which is also for nurses, ECMO specialists. It's got a wealth of information, and I think it's a great app. We're going to be doing a revision. We've gotten some great feedback and suggestions, but the app is selling. I need to sell 1 million of them so I can retire, so please, one at a time, just keep buying it. In fact, buy it for your kids on their phone. It'd be great. And then we also have the nurse's IV dosage and rate calculator, or for CRNAs. This is a really cool app, and it's actually in the critical care app, but it's also standalone. One is $2.99, the other one is 99 cents, I believe. Both are great apps, but you get both in the critical care app and perfusion app, so keep that in mind. And John, this is for John Ingram. So I got his attention. I can see him. You can't see John yet, but I can see him. So you wanted to know about new things we're doing, which I told you. If you go to Google and you type in PerfWeb Podcast, you will find us on any of your favorite, how do you say, your favorite podcast service?
Yes.
Whether it be Apple Podcast, Google Podcast, Podbeam, Spotify. You're driving in the car, you have Spotify, you can tune us in there. Amazon Music, TuneIn, and Alexa, and iHeartRadio. So you can find us there. There's John. Hopefully when you pop on, I'd like to know what you think about our podcast, but it's a great way to listen to the program while you're driving your commute, stuck in traffic, whatever the case may be, or even watching an ECMO with one earbud in. So whatever you like to do. Okay, so let me introduce our esteemed faculty. First of all, to my immediate right is Tammy Sparacino. This is, of course, Tammy Sparacino's Journal Club. I think we're going to be changing the name. John, you had come up with a really catchy name, but I can't remember it. And then to follow the Journal Club program, we're going to be having the second installment of John Ingram's Knowledge Nuggets, which was a great thing that you had come up with. I just absolutely love the name. So we do need to get with the Tammy's thing. There was one other thing I wanted to tell you all, and I can't quite remember what it was, but I do want to say this. John, I don't know if you're seeing this as well. The last 3 weeks, and I've been doing this job for a long time. I won't say exactly how many years it's been, but it's been a long time. This has been the most trying 3 weeks of my career. I have, in a 3-week period, you know, I've dealt with disasters. I've dealt with hurricanes. I've dealt with earthquake, mass casualty events. I've dealt with gunshot wounds to the chest. I've dealt with some very dramatic events. But in a 3-week period, I have worked more, harder, with more difficult and demoralizing outcomes from COVID than I ever have in my entire career, which spans 4 decades. I mean, I'll just say that part. I won't say exactly, but it's 4 decades at this point in time. I'm deeply affected by this, and I think everybody else that we work with is as well. Houston went through a hell of a second surge. The nurses and the care that I have seen them give patients has absolutely humbled me. Our team and the dedication of us working essentially around the clock, managing that plus doing hearts. Things are getting better, and it certainly seems the numbers are trending down. But I just want to say for anybody else out there that has experienced what we have in this 3 weeks, you know, my heart goes out to you because this has been the toughest time I've ever experienced. Tammy, what say you?
It's been very difficult. It's one thing to have to do the work, you know, and know that you're going to be working longer, you're going to have to be flexible, you're going to get less sleep, but it's the...
And you're going to be on call essentially for 3 weeks straight.
Yes, on
at
call
least.
All the time. But it's that, I think you can do that for a good period of time if you have some encouraging outcomes, but we're not having hardly any at all, and so it's very discouraging to see these patients suffering, and it's just continuing. You know, the work stress from the additional hours alone, and then add to it the poor outcomes.
Demoralizing outcomes.
It's just terrible.
John, what are you seeing?
Yeah, pretty similar. Is my microphone okay?
It's a little scratchy, but not bad.
It's flashing, so I can go to another mic if it's acting up. But yeah, I mean, it's the same as we've been for the last month. We're doing 18 or 20 ECMOs at all times a minute. One comes off, we have a line of people ready to go on, whether it's in-house or in the surrounding areas, and we're turning down calls almost every day for people saying, can you please take our patient? You know, they don't do ECMO, or they just don't really consider themselves an ECMO program, and we're having to tell them no, we're definitely out of staff, and sometimes out of beds, and equipment's being stretched absolutely to the limit. You know, we have a lot of cardio helps, and we also have a lot of CMAGs, and with CMAGs you cannot hand crank those, so you have to have a backup either nearby, and especially if you're going to travel with a patient to the CT or to the OR, you can't just go solo on a CMAG unit. God forbid it fails and you have nothing you could do.
Wow.
So we're having to keep record every day. We have a chart of where all the equipment is, where our backups are they on a patient, and all of a sudden, you know, it's changing hour to hour sometimes.
Wow.
Well, I mean, that's a very good point. And I had a very good conversation with one of the medical directors, the CMO at St. Luke's, the Woodlands Hospital, Dr. Raza. And what's encouraging, there's two things that I want to discuss, but the encouraging part is he's telling me they're giving these patients the monoclonal antibodies when they're not in the hospital yet, the Regeneron. And it is apparently, according to him, working very effectively and keeping people out of the hospital. So that's being used, and I'm assuming it's still emergency use authorization, but that's being used more frequently. And that's what was given to, you know, our former president when he got sick, and what he said made him, that and the steroids made him feel so much better. He was out of the hospital in no time. He went in and came out, which is remarkable given his, you know, his risk factors were huge.
Sure.
Age, obesity, you know, and various other things. But John, this is the thing that I wanted to bring up, and Tammy as well, is I'm feeling like in the first wave, our outcomes were so much better, and I believe that was because it was novel. We didn't have that many cases. You came into the hospital, you were treated maybe with remdesivir, you failed that, you got the plasma, you got intubated, you went right on ECMO, and for example, the police officer that we did, the guy who shut Houston down, essentially, that our patient zero, I guess, is what you would call him here in Houston, did so well, and actually says that he has better cardiopulmonary capacity than he had before he actually got COVID. But now I feel like we have such delayed treatment. They're doing everything they can to keep the patients from going to the hospital because there's no room. Then you get the patient to the hospital and everything is done to keep them from going to the ICU. And then they make it to the ICU and intubated now, and they do everything they can to keep them from going on ECMO because you run out of ECMO. We have none left.
Yeah.
And then you finally put them on ECMO and they just get this horrible fibrotic lung disease, and their lungs turn into bones. And they're weak bones at that, because we've had several who have just had lungs literally rupture, and then you have these tension pneumothoraxes, and you have to put chest tubes in, and they just don't improve. Their lungs volumes get smaller and smaller.
Shrink.
Yeah,
Shrink to
they
nothing.
just become rigid, and they and the ventilatory pressures, airway pressures go up. The volumes are coming down, and eventually the whatever tissue that is, that fibrotic tissue, just breaks loose. And this has been very, I'm going to tell you right now, it's, I think there's going to be a lot of perfusionists, a lot of nurses, a lot of doctors that are going to have PTSD when this is over with, because it's been 3 weeks of absolute hell.
Joe, Tammy, have you seen this before COVID? You have a patient, they're on ARDS, they have, aspiration pneumonitis, maybe they even have the flu, they go on ECMO and stuff, but I can never recall seeing what we see so frequently now with what you just said about the fibrotic lung disease. For people listening, a normal tidal volumes are somewhere around, 450 to 550 cc's of air is normal tidal volumes. We get these patients 10 cc's tidal volumes, 15 cc tidal volumes.
Yeah.
And I mean, if you understand what that is, you're not even filling, you know,
The dead
the
space.
nasal cavity.
The
You're not
airway.
filling anything.
Yeah, ours are running about, I think the worst I've seen so far is 30 cc's, but we have several patients right now with lung volumes of 80 to 120 with peak airway pressures of 40. And, you know, for those of you that don't know, I mean, I think everybody that's really watching this program probably knows this, but in case it's somebody that doesn't, normally when we breathe, we create a negative pressure and the air is sucked into our lungs versus a ventilator, which is a positive pressure. And of course, when you have airway pressures of 40 with lung volumes of 100 or 120 or even 70, the amount of barotrauma, the bruising of those lungs is just sometimes too much. So you have two problems happening.
You need about 100 cc's, maybe 120, to make it through the large bronchi and even into any possibility of getting into the alveoli.
Right.
So what's happening is you're pumping air or oxygen in and out, and what you're hoping for is that the stale air in the alveoli is going to diffuse and mix with this air that you're pumping in and make its way out.
Yeah.
This is really not even true ventilatory support. It's really working on, hopefully, the law of physics will give you some diffusion of oxygen to the end point of the alveoli.
But then can it even diffuse because the alveolar capillary wall is so sclerosed that that normally that gap is, you know, is so small, it's almost immeasurable, and then it thickens and becomes rigid, and the gas can't diffuse back and forth across. So we see CO2s rise, we see PO2s plummet. Very difficult situation. And then and we're, you know, just so you know, we're doing now a lot of our ECMOs without anticoagulation. So you have taught us something out here, and it has tremendously helped with the coagulopathies from the, you know, insertion site bleeding and so forth. Now, we started off with Plavix and aspirin, but we've since then actually transitioned even away from that. And then I think, for example, Tammy's talk today is going to be a lot about CRRT. I'm going to bring that up as well, and organ crosstalk, but you can regionally anticoagulate your CRRT machine. You can't regionally anticoagulate your ECMO because it would require too much volume because the flows are just too high. But you can do it on a CRRT machine with, let's say, flows of 200 cc's a minute versus an ECMO at 5 liters a minute. You would have to use an incredible amount of ACDA. It's unfeasible. It just can't be done. So thank you for that, John. Can you tell me the name of what you thought Tammy's, instead of Tammy Sparacino's Journal Club, what did you say it should be?
Well, it's Tammy Sparacino's Journal Club Casino.
Yes.
Tammy Sparacino's Journal Club Casino. I like it.
And
Do you
so
like
if you
it?
can figure out something of an unknown, whatever that could be, you know, like when you go to the casino, you don't know what you're going to get when you put your $20 on red, right? You don't know what's going to come up. Or if you're in the craps, you don't know if your 7's going to come up or not. So a little bit of an unknown, and there you go. That's going to be what we're going to get.
David, can you figure a graphic out for that? Thank you. Okay, good. David's on it because we're going to do that. Do you mind?
No, I think it's
okay.
great.
So with that said, I know we've probably belabored a lot of this already, but I think this is very important. People need to hear what's going on and understand just how devastating this has been. And I don't want to belabor the point, but I'm going to tell you right now, the perfusionists, the critical care physicians, the cardiac surgeons, the pulmonologists, and the critical care nurses, and even the nurses taking care of them in the COVID units, trying to keep them from going to the unit. I'm humbled at what I have seen. I've always respected everyone, but this has given me definitely a new level of respect that I didn't think even existed. It's that high. So I appreciate you, John. I appreciate you, Tammy, and anybody else out there taking care of these patients. So, Tammy Sparacino. Let's go. Let's spin the wheel. Black or red?
Okay. All right. Today we are going to be discussing a commentary article that was published November 2019 in BMC, Biomed Central Nephrology. The title is Optimizing Renal Replacement Therapy for Patients Who Need ECMO, Crosstalk Between Two Organ Support Machines, and the primary author is Kashani. Okay, so here's our abstract. Following a substantial increase in the utilization of ECMO during the last decade, its associated benefits and complications, including acute kidney injury, have become more apparent. Acute kidney injury requiring dialysis during ECMO treatment is very common, some say 30 to 70%, and it's associated with adverse outcomes. Crosstalk between the ECMO and the dialysis equipment have been debated in literature in order to enhance the quality of dialysis and avoid its potential adverse events. This commentary is about another article that was published just a year earlier by primary author Na. They published the results in a prospective experiment by using 3 different methods of integration of continuous renal replacement therapy device into the ECMO circuit. In this experiment, the investigators showed that by using 3 different connection strategies between CRRT therapy or CRRT device and ECMO, the utilization of 3 separate structures of pressure control lines, the dialyzer lifespan could be optimized. So this commentary is following a brief review of the ECMO and dialysis device history crosstalk, and they'll discuss the findings that were published by Na. Okay. So we just talked about why this paper is published. It's published because ECMO utilization has gone up substantially in the last few decades, and increasingly very current topic for us as well. And ECMO has its own set of adverse effects, one of which being AKI. So the need for CRRT is actually quite common with ECMO patients, even ones that have no prior kidney issues. Okay, the problem to solve is they're trying to find the best way to be able to, first off, connect the CRRT machine in line with the ECMO, and the benefits for that would be you don't have to put in an additional catheter. Patients on ECMO are often on anticoagulation, and so or coagulopathic, so you can have bleeding problems. So obviously, if we are able to integrate it into the ECMO circuit, then we're avoiding some of those issues.
Also, you know, if you don't mind, can you mind if I talk at the same time?
Come on.
So, just very quickly.
And if you don't know this, CRRT is one of Joe's passions.
No, but thank you, but you're bringing up a very good point, is you may be stuck now having to stick the femoral. So you're using an Avalon or a Crescent.
Yep.
You have the neck, you're able to sit the patient up, do all that stuff. And if you're adding a Quinton or a Maherker catheter or a temporary dialysis catheter, whatever you want to call it, and you're having to go femoral, you have increased infection risk. And although they use ultrasound, there is a risk of hitting the artery. And if your patient is coagulopathic, now you got a bleeding problem. And you'll get a pseudoaneurysm, you get all kinds of problems. So I think that there's really, really important, you stress the point, I think, of integrating what you can in the ECMO circuit, but sometimes you can't, and there's reasons for that. I know you'll talk about it.
Yeah. Okay. So how did they do it? Well, since this is a commentary, I'm not going to go into the how method procedure too much. We're going to actually discuss the original article a little bit later, so we'll just kind of get through this part, and we'll circle back to this. So here's their conclusions. All right, so they concluded that the article they're reviewing, having a commentary on, has the analysis offers a path to better understanding of the crosstalk and provides options on how to overcome challenges related to intra-circuit pressures in order to optimize treatment. So really what they're talking about is CRRT machine, and I'm no expert, but there are several pressures that the machine reads and therefore knows that it is flowing correctly, that the pressures aren't too high, because it's set up to be directly connected to a patient. Now, those pressures are going to be different and have different ranges when it's going to be connected to the ECMO circuit. So those are some of the challenges that you're going to have when you are connecting it to the ECMO circuit, because the device has these pressures as safety measures. And so you're going to have constant alarming if you're not able to overcome the pressures and get them within the right or the correct ranges that the machine is made to expect. Okay, so here is the original article that they were doing commentary on, and you can see it was published in the same journal, published about a year prior. So their commentary was November 2019. This was December 2018. So this was a research article by Soo Jen Na over in Korea, and the title is Using Additional Pressure Control Lines When Connecting a CRRT Device to an ECMO Circuit. Okay. So it tells you a little bit about the background, which we've kind of already gone over because it was covered in the commentary. But what's interesting is, I'll just read what we were talking about the pressure. So when you introduce a device into ECMO, it can be, it's starting to become widely used. However, excessive pressure transmitted to the CRRT device is a major disadvantage. We investigated the effects of using additional pressure control lines on the pressure and the lifespan of the CRRT circuit connected to the ECMO.
Mm-hmm.
All right. So they have three groups that they looked at. So this is the setup that they used for their group A, and you can see that it's the CRRT is connected prior to the pump head for the return, and for the access, it's in between the pump head and the oxygenator.
No, it's the opposite. So the access is the drain cannula. Oh, I see what they do. No, you're right.
Yeah.
They have it there. Yo, I see how the arrows.
Yeah,
okay.
Don't get confused on the arrows. The CRRT arrows are the larger arrows that are directly above the CRRT drawing.
I got it now.
Okay,
yep,
got
thank
it.
you.
The other is the flow of the blood
Here, you want to use the mouse?
to and from the patient.
That confused me.
Okay, sure.
Tammy, can I interject something?
Sure. I can't see the mouse though.
So if your
There we
post-membrane pressure line is feeding into the CRRT,
There it is.
and your post-pump pre-membrane line is feeding the CRRT, and your pre-pump line is exiting, which means you have a high pressure, very high pressure line coming in, and a very high negative line leading out.
Correct.
If you're standing from the standpoint of the CRRT device.
Correct. I think they
Well,
were trying to get
That's going to be difficult. That's going to be difficult to manage. I can tell you that.
Yes.
John, I've got some ideas on this too, but that's a very good point. I'll show you what I do, but I'm going to let Tammy get through this, but that's a very good point.
Okay.
And we don't have a mouse, so they're fixing the mouse.
Well, it's
and
okay.
then we'll go from there.
So I mean, if you just look at the CRRT device and you see from the drainage cannula, that line connecting to the CRRT, if you look at that arrow, that's where we are returning the blood into the circuit.
Right.
Okay?
They're going from high pressure back to negative pressure.
Correct. All right. Now, on the next one, they do the exact same thing, so the setup's not different, but you'll notice that on the access, there's a little addition of a pressure control line before it gets to the CRRT line. And the pressure control line is just a smaller line that has a smaller diameter lumen, and they're just using the idea that smaller lumen will cause greater resistance, which will slow down flow, which will lower pressure.
Dampen the big
exactly.
pressure head.
Exactly. Okay, so that's group B. All right, group C, the same setup, so they're still accessing and returning in the same place, but now they have pressure control lines on both the access and on the return. All right, here was their conclusion, that The primary outcome in this study was that the lifespan of the CRRT circuit, which is important because, you know, if the longer you can make the filter last, the less interruption of care, one, less blood loss, because if you do not change your filter soon enough, you can lose all the blood that is within the circuit.
Yep.
Okay.
180 cc's of it.
Yeah. Secondary outcome were pressures in the CRRT circuit and changes in laboratory findings indicating hemolysis and thrombus formation before 24 hours after CRRT initiation. The clinical outcomes, such as rate of weaning from ECMO, duration of ECMO support, adverse events during ECMO, and in-hospital mortality were also identified through a medical record review. Okay, so here's the main point that I wanted to get to. There's a lot of data here, but you can notice that the first column is just the parameters that we're looking at. Second column is the group A, the no pressure line group, so it's the unaltered circuit. They had 16 total patients and circuits that they used in that group. The second one would be, the third column would be group B, the single line. So there's only the pressure line on the access. They had 36 of those. And then group C would be the double line group. They had 118. And you can see there's a lot of statistically significant p-values. Of course, the pressures are going to differ with the groups. But if you'll notice that the no line group and the single line group, if you're looking at the pressures other than the access pressure, they're going to be the same, right? Because you're only altering the access pressure site. When we go to the double line group, look at the incredible difference in the pressure. So filter pressure goes from, you know, in the negative numbers to a positive 119, and the access pressure goes to a very small positive 2, and the return pressure from, you know, negative almost 100 to around 68.
What's very important here too is that effluent pressure, and I'm going to talk about that.
Yeah, I'll let
here.
you talk about that.
Absolutely.
But you'll see I really just highlighted the main outcome, which is the lifespan of the CRRT in hours. Group A, 21 hours. Group B, almost the same, 23 hours. But when you get to group C, the double line group, it nearly doubled from the single line group, and definitely doubled from the no line group to 45 hours. So it is significant.
Makes a big difference.
Yeah.
And I can, yes, and make sure you remind me because I can tell you why.
Okay. All right. So, look, hey, tell me why.
It's a long discussion.
Okay.
Oh, it's time?
Well,
Okay.
we have a mini discussion here, or I can move on to kind of the more of the topic that I'm going to talk about.
Let's move on to the topic.
All
We'll
right.
come back to this.
Okay. Okay, so this is, I thought what we talk about is just, since these articles focusing really a lot on placement of the CRRT within the ECMO circuit. So we're going to talk about location considerations just in the literature and what I was able to find. And then I'm going to let Joe talk a little bit about what we do in our practice here. And then John, if you could chime in to that as well. Okay, so this is one of the older published articles that I found on integrating CRRT into ECMO, and it was published in April 2010 in the European Journal of Cardiothoracic Surgery, and it was simply just how to perform hemodialysis using the arterial and venous lines of ECMO. It was published by Rubin. Okay, here's the abstract. Continuous renal replacement therapy is particularly suited in the setting of acute renal failure occurring after cardiac surgery in patients requiring, ECMO life support or any membrane oxygenation. In such patients, temporary catheters are not necessary since the circuit of hemodialysis or hemofiltration may be connected to the ECLS cannula. We report how to modify a classical ECLS circuit in order to accommodate this. They use the prism effects, and they, in their practice, they actually modify all of their ECMO circuits as described here. They had been doing, since 2004, 21 patients had been treated described here. So they looked at about 6 years of how they had been integrating it into the ECMO circuit. Okay. And we'll just talk about real quick their summary. So they talk about that the arterial blood is taken from the corresponding line and re-injected into the venous line. So they set it up similar to, different than either of the other two. This is the original article where I could find where you take from positive post-oxygenator and return to negative pre-pump.
Correct.
Okay. And they, let's see, they talk about the stable blood flows, but what they're mainly wanted to talk about is just their placement. So they've done something completely different than what the other two articles had. All right, and here's another article, CRRT connected to ECMO, this managing high pressure. So you can see the pressures are a big focus. This was published in OSIO in February 2017.
That's an excellent journal, by the way. I love that I really like this organization.
Yeah, I do too. I find lots of great stuff in there. Okay, so here's their abstract. So they talk a little bit about why they want to use CRRT, but they're looking at, so let's see, connections were performed according to standardized protocol to maintain CRRT lines in the correct pressure ranges without modifying ECMO settings. In other words, not going down on your ECMO flow because your patient needs that flow, or inhibiting pressure alarms. To achieve this goal, the way of connecting the CRRT line was adapted following a standardized protocol. Connection was first attempted between pump and oxygenator, so that was in between on positive pressures on both of them. In 5 of the cases, high pressures in the CRRT lines were successfully managed by changing the connection segment. Continuous renal replacement therapy parameters were within target levels, and reduction of serum creatinine was 37%. In conclusion, management of high pressures in the CRRT lines induced by ECMO could be achieved without modifying ECMO blood flow or inhibiting the alarms. Okay, and here's how they did it. So they also had 3 groups, or 3 options, they called it. So the diagrams are kind of small, and that's fine. I'm really just going to kind of go over the big picture here. So option 1, the pressures in the CVVH access line less than 200 and the return line less than 350. They talk about the advantages. So if you're doing it in where you are putting it between the pump and the oxygenator, there's no risk. I mean, I guess there's always a risk, but they say there's no risk of air embolus. The return line is connected on a positive pressure, no oxygenation membrane shunt, and no recirculation. Drawbacks: the access line is connected on positive pressure. Okay, option 2A. You'll see that they are on the negative side for access, and then return line is on the positive side, between the pump and the oxygenator. So the advantages are access line connected on a negative pressure, return line connected on a positive pressure, no oxygenation membrane shunt, no recirculation. The drawback: hypothetical risk of air embolus.
Yes.
Okay.
Yeah, it's not a hypothetical risk.
Well, that's just how they stated here. Okay.
It's a very real risk.
Option 2B. You'll see that everything, access and return, are on the negative side, so prior to the pump, and they're used for high pressure positives in CVVH return line greater than 350. The advantages: access line connected on negative pressure, no oxygenation membrane shunt, no recirculation. The drawbacks: there's a theoretical risk of air embolus, the return line connected on a negative pressure, but a clamp can mitigate negative pressure on return line in case pressure below the low pressure alarm. All right, that's everything. So those are all the variations that I could find on ways to connect to CRRT. And you can notice that, of course, safety is the primary concern in all of them, but really managing these pressures is the biggest challenge.
Absolutely. And so I think that's a very, very good point. You know, and I know they really didn't, you know, that these studies that we had, this article, you know, it really didn't dive into the organ crosstalk. And John, you gave a beautiful lecture,
Yes,
actually,
very
just
nice.
recently on organ crosstalk, which I highly recommend people go and view. You can find it. I don't remember what perf web it was, but you can find it by typing in John Ingram organ crosstalk, and you'll find it. I have also a really, I think I did some nice slides, but in deference to time, I think that it's going to be, I think, impractical for me to give that lecture, because I really get into what is organ crosstalk and what are all the various things. And it's a very good lecture, but I'm going to hold it, I think,
Okay.
until next week or next show, next program. I'm going to hold on to it because I think I don't want to go too fast through it because there's so much really good information there. But Magic, I sent you a bunch of photographs. Is there any possibility that we have a mouse yet that works?
Yeah.
So,
So,
Joe,
John,
Joe
go ahead.
and Tammy, while you guys are sort of getting some things together on what you said there, yeah, I find it fascinating because we do not use any high pressures on any of our CRT. We use all negative pressures, both access and return. But going back to your first article where they did the group A, B, and C,
Well, let's go
and
back to that
regulated the
slide.
pressures on both the access and on the return, and they jumped up their life of their CRT device
back.
nearly double, from about 23 hours up to
yeah, wait,
Here.
right there.
45 hours.
Yeah.
But I can tell you at our institution, if we have a CRT device, disposable, that lasts less than 72 hours, we are disappointed.
Yes.
Ours lasts 3 to 5 days.
Are you using regional anticoagulation with citrate if you're not using systemic heparin?
I believe they do. I'm
Yeah.
really not a good expert
you
on
have
this, Joe.
to.
You're really
You
the
have
expert
to.
You
here.
have to do
But
something.
put that slide up, John.
I
But throw
believe
that
if
slide
we,
up.
if
Hey,
we
John.
do not have anticoagulation on our, that they do use
Yeah.
the ACV on the
Yeah.
hemodialyzer. Yeah.
Yeah, let me put that slide up. David, throw that slide up and then let John talk about it, what he was talking about just now. There you go. Yeah,
Yeah,
that's
yeah,
it
so,
right there. Yeah.
So just so people know, if you're going through a filter every 24 hours or even every 48 hours, I think you need to address see if you can improve, because we would consider that problematic. We consider less than 72 hours problematic.
Well, 72 hours is your max, right? The filters time out after 72
Yeah, they
hours
count
for
down,
a variety of reasons. But that's the life. That is the maximum allowable life time of any CRRT filter. And so you don't want it running for long. It won't run for longer than that. It will time you out, and it will force you to change it.
Well, which machine? The machine is telling you to time you out.
Yes, and there's a lot of reasons for that. You know, the filters within the CRRT machine, and it depends on which one you use, but they have dominantly it's a polypropylene style of hollow fiber, and the others are a polysulfone hollow fiber. And some people say that the AN69, or there's various different ones out there, tend to be a little more reactive, and patients can have a little more of a allergic reaction, a little more hypotension, probably some histamine release or something like that. The polysulfone tends to be a little more gentle. You don't necessarily see that. I prefer that filter dominantly for that reason, but there is a charge on the polypropylene fibers or polypropylene style filters that is more capable of adsorbing the larger inflammatory mediators that won't come through the filter because of the pore size, which is cut off at 55,000 Daltons. It's 50 or 55,000 Daltons, in that range. That's why protein or albumin won't come through it. Only plasma water will come through. But you still can have adsorption of these various larger molecules by the charge that is expressed by the filter media itself. So that's kind of how that works. But what I've noticed too, John, I think your point is well taken, is I'm looking at the return pressure and I'm looking at this effluent pressure. So the return pressure here, which is negative, and your effluent pressure is grossly negative. So can you guys throw up that the one that shows the entire CRRT machine with it was the last one that I sent. All right, well, 30 seconds. Okay, we'll wait 30 seconds. So what I'm going to do is I want to go over very quickly just an overview of the machine, the one that we use. So there are different machines out there. Okay, there's the Prismaflex, there's the Prismax, which is made by now Baxter bought Gambro. There used to be the Braun machine, but that's been off the market. I know they have one in Europe that they're trying to get back into the United States. I think Braun does a good job. There's the Next Stage machine, which is, it's popular. People use it. There's some advantages to it. There's some disadvantages to it, but the Next Stage machine was really a home dialysis unit, which was then modified to be a CRRT machine. And look, all of these machines work. I'm not saying that one machine is just inherently better than the other, but if you use a different machine, that's fine if it works for you. I have a personal preference, even though I don't like the company Baxter Gambro. I don't like them at all, as a matter of fact. But regardless of that, I feel like, in my opinion, they have the most effective widget out there to do what it is we're trying to do by controlling volume, controlling acid-base balance, controlling electrolytes, controlling, and to some degree, controlling, medium-sized pro-inflammatory mediators. It's not going to take out the giant ones, but it's going to control some of the more mid-sized ones, and I think it does work very well. So go ahead and throw that picture up, and I'll just go over it very quickly. And remember these pressures, these effluent pressure, return pressures, and effluent pressure, filter pressure, and of course your access pressure. And just look at these numbers. And this is so high because it's hooked up to the CRRT machine.
Wait, you're
under
pointing
high
to something
pressure.
that's not up there.
You asked about the picture of the CRRT machine.
Yeah, but I want to see this graph at the same time. I don't want to see me. Nobody wants to see me. I look old and tired. Nobody cares about me. Let's see if that's possible.
Yeah.
Both of them up? No, I want to see both, the machine and that together. Is that possible?
And none of the...
It's pretty wide.
Okay, well, that's fine. Just put up the CRRT machine and not me. And I'll just go over it. Okay. We're usually not this bad. But,
there you got a little bit
but
of
I
both.
can't see it here. So I can't... I don't know what I'm pointing to. We don't have that capability? Okay, so if you look at this machine, what you'll see is you'll see 5 pump heads. And this is the Prismaflex by Baxter Gambro. If you look at the top left, that is your effluent pump. If you look at the second smaller one below it, that is your pre-blood pump, which is where you would run ACDA if you were using citrate protocol in order to regionally anticoagulate your CRRT machine without anticoagulating your patient. And that's very easy to do. You just have to know what you're doing, and these protocols are published. They're very easy to find. If you look at the top right pump, that's just to the left of the top of the filter, that is going to be either your post-filter replacement or it will be your dialysis pump. So you can run this as CVVHD, which is essentially just continuous hemodialysis. And let me just go through the next pump. The one directly underneath that is either going to be your pre-filter replacement pump or your pre-filter and your post-filter replacement pump. And I'll kind of explain that. It can go either way because there's these little valves that change where that fluid goes into, either pre-filter or post-filter. Both of them can be post-filter, or one can be post-filter, the other pre-filter, or they can both be dialysis. And that's sort of how it works. So when you hook it up to an ECMO machine, and you have, and let me just go through the rest of the overview. If you look at the very top right in the green section, there's a line that's going into the machine. That is your return pressure port. That's going to read the pressure in the line going directly back to the patient, nothing else in between it. If you look immediately to the left, that is your effluent pressure line. If you look on the bottom right, you'll see another pressure pod. That is your pre-filter pressure pod. And then to the left is your access pressure.
Yeah.
So you'll see in the big pump, of course, is your blood pump. So I think everybody now understands that. The thing to the right is a heater, and then you have the screen, and you have your replacement bags down below, and you have your effluent off to the left, and you can see it's yellow. This patient happens to be in a severe liver dysfunction and probably really acute liver failure at this point, and so you'll see yellow. It's bilirubin, because it really should be clear. So as their bilirubin is rising, you're going to clear that to some degree. So when you hook it up to the ECMO, if you hook that return line up to a negative pressure, it's going to constantly be pulling because your pump is, that
Sucking.
access is sucking. It's
Yeah.
negative. And you can actually cause that deaeration chamber to get lower and lower and lower until eventually it will suck air if you're not constantly adjusting that level.
Seen that happen.
Okay. The other thing that happens is when you have that under very strong negative pressure, the effluent now, instead of, because the filter itself is under negative pressure because
It's
everything is
sucking down.
pulling. And what will happen is that pump in the top left, your effluent pump, has to fight against it and pull the fluid across the membrane to get it into the effluent bag. If instead you have it into a positive pressure environment, then instead of pulling the fluid across the membrane, the positive pressure is pushing the plasma fluid across the membrane, the plasma water across the membrane, and that pump is now only acting as a dam to control the amount of volume you're removing.
Okay.
If you leave this filter under negative pressure so long, you will essentially just disrupt it because it's not meant to work in that kind of environment. And all of the pores will end up getting clogged up with stuff that I said could adhere, right, adsorb to the filter media. Instead, it's getting pulled and it starts clogging up all of those little pores in the fibers, and you'll eventually, it'll say filter clotting. It can say clogging, but it can say that, but it rarely does. That's usually your transmembrane pressure keeps going up and up and up and up. But usually it'll give you an indication that it's clotting. So can you put up the other picture of how we hook it up? So this is what I do, and this is what I like. Because remember, this pump is supposed to live in an environment that is a temporary dialysis catheter. Your access is going to be negative naturally because you're pulling through a small catheter in a big vein. Your return is inherently going to be positive because you're flowing 200 to 300 cc's a minute through, if it's an 11 French catheter, only half of that is your return. And probably really the smaller size is your return because you want your access bigger, right?
Mm-hmm.
So it's probably down around 4 French or 5 French at best. And so you have that resistance. And so that's what the machine is actually looking for. So here's an overview of how we have it hooked up. So go to the next picture where there's the close-up.
Okay, so that's the access.
Mm-hmm. There you go.
Okay.
Okay, so what I do is I put the access, and very similar to what your guys talked about. If you can see in this picture, and I don't have a mouse to do this, so I'm sorry, I just can't do this. I'll
identify by
just
color.
articulate this, right? So if you see the line coming directly at you from the lung, that's our return line. It's red. And you see it has a smaller line, and then you see the red access of the CRRT machine connected to it. Now, dialysis and perfusion are exact polar opposites. To us, access is blue, and return is red.
Yes.
But in the dialysis world, red is access, and blue is returned. And the reason for that is, as you concentrate blood, you've seen it when you're just doing ultrafiltration on the pump, the blood coming out of the top, when it gets really ultrafiltrated strongly, always looks darker. And that's why they're opposite of us. So I use a smaller line, and that helps to dampen that really strong positive pressure from the pump, because that pressure is going to be 250, 300. And the machine is just not designed to manage those kinds of very hostile pressure environments. It's used to seeing a negative pressure on the access because it has to pull from a temporary dialysis catheter.
So
Then,
if I may interject real
please.
quick. So if you're doing this and you're attaching your access, having a smaller pressure tubing type line
Dampens the pressure.
it's just like what this article
Exactly as they said.
So we're doing exactly what they said.
Exactly. The only difference is we are returning to, and if you look down where that yellow stopcock is, where you see the blue line. So if you look to the left of the red, you'll see a little blue nub attached to a yellow stopcock. That is the return going into the negative pressure side of our pump. Pre-pump. But I don't want it to be a negative pressure.
So you give it a big line.
No, I want it to be a positive pressure, because that's the return. I want my return pressure to be positive, because that's going to make my filter pressure positive, is going to make my effluent pressure positive. So if you see where I have it coming in on that stopcock, you'll notice, if you look very carefully, I have that stopcock turned, and I turn it just enough, and it takes some finesse. You got to work at it. It usually takes me 4, 5, 6 little teeny turns till I get the pressures where I want them. And I'll show you the screen and what I like my pressures to look. So even though that pressure is very negative, it's actually positive for 2 reasons. I created a little resistance to the pump flowing back to it, and if you notice, I have a great big recirc line coming off the top of the oxygenator that you see going back by the pump head, by the centrifugal pump, and coming down and going back to the return. So I actually have a combined positive and negative pressure in that one line. Does that make sense?
Yes.
Okay, I hope that makes sense. I'm sorry I don't have the ability to point at all of this, but I'm telling you, if you want, we'll redo this, or you can send me an email and ask me to try to redo this again. I'll explain it to you. It's really very simple. But what's so critically important here is, if you lose your red access line for any reason, you're probably going to notice it, because you're going to have well, let's say a pond. Hopefully you'll catch it before it becomes a lake or an ocean of blood spraying all over the place. Kind of recognizable if anybody's paying attention.
Right.
And a person on ECMO is not left alone, ECMO and CRRT. The thing that scares me the most, and at the end of the day, this is something that is going to be debated forever, and of course, I'm an advocate of nurse ECMO specialists, very much so. I think we need them in order to be able to manage the kind of patients we're going to have in the future, now and in the future. I wish we had them now. We need more of them. Yeah. Perfusionists are just too few in number. But if you mess up that line, if you mess up the access and get that open to air with that kind of negative pressure coming from that pump.
You said access, but if you mess up the return.
Well, I mean the return line of the CRRT, access to the ECMO.
Okay, gotcha.
Right?
Right.
It's going to suck massive amounts of air,
Yes.
deprime, and you're going to have one heck of a fire drill on your hands. And if you're VV ECMO, probably get away with it. If you're VA ECMO, you got a big problem on your hands. So you really have to be skilled, trained, experienced, know what you're doing before you go endeavor on this kind of a procedure, because I'm down there connecting this thing and making these adjustments, and I am checking every 15 seconds all of my connections are good and strong, because I'm concerned that could happen, and I know how difficult it is to get out of that jam.
Well, and we do this so much. We've made that a part of our circuit inspection multiple
Yes.
times a shift, is checking your stopcocks,
Correct.
checking your connections to your CRRT or whatever you have added into your circuit.
Absolutely. The other thing that I have to point out, which is a fair criticism of my system. I don't have a problem. I think it's a reasonable criticism, and I want to re-examine yours to see if we need to change to this. And I'll tell you what that criticism is. I'm taking the blood from the return to the patient to access and returning the blood to the access to the ECMO. So you will have some inherent recirculation. However, if we're flowing 200, and this is my philosophy, okay, and I'm just saying you can take take these pictures down just for a second, and then we'll put up the other picture of the front of the device. But this is my philosophy on that, is that if the amount of recirculation you're going to have when you have only 200 cc's flowing through your CRRT machine, and you have, oh, that's perfect. Oh, that was good. And then you have 5 liters going through your ECMO. The amount of recirculation, in my opinion, is going to be negligible. And if you wanted to flow 200 and you wanted a replacement volume of 2,000 or 2,500, then just turn your blood flow up to 250 and your replacement to 2,500 or 3 liters. You're going to more than overcome whatever loss of therapeutic value or dosing, as you would call it, by doing it that way.
So can I ask a question? So really, when we're talking about the recirculation, it's not the recirculation from the ECMO circuit back having another pass through the oxygenator. It's the recirculation of the blood that you're treating with your CRRT machine.
Yes.
You're not getting the exact correct ratio.
Yes, because you can put your flow probe distal to your access, which is coming out of the red, so it doesn't matter what the recirculation is. You know it's going to be 200 cc's a minute coming out of there going to the CRRT machine. If you wanted to flow 4.8 liters, you have to turn it to 5. If you wanted to flow 5 liters, you need to turn it to 5.2. Or you can just put the stopcock distal to the access.
Flow probe.
The flow probe, that's what I meant. What did I say?
Stopcock.
Oh, the flow probe is what I meant.
So it's really it's a shunting that you're worried about for the CRRT machine, not for shunting oxygenator to the patient.
It's 200 cc's.
Right.
I've got that big shunt open anyway. We leave that shunt open. That's a big time shunt.
Well, and that's what I was having trouble trying to figure out, why they were so concerned with that. But it's from the CRRT perspective.
Yes, if you're trying to treat the patient with a certain dosing, let's say let's just say 25 cc's per kilogram per hour of replacement fluid, which means you have to remove 2,500 and give 2,500 of a different plasma water that you want it to look like, right, that you removed, and you're having any recirculation, that number will come down. But it's so easy to compensate, and this has worked for me very, very well. Can you put that last picture up, and then I'll be done with this. So that same patient, and these pictures, by the way, were just taken this morning. So that last picture of the face of the CRRT machine, there you go. So these are the pressures that exist on any CRRT machine. It doesn't matter which one it is. Again, it's just the one that I use. It's the one that I like. It's the one I prefer. And I really like their Prismax, like I said. I tell you, I'm just going to be blunt. I can't stand the company, but they got a good device. There's just no arguing about it. But if you look here, you'll see the blood flow is 250. The pre-blood pump pressure is 50. And that's basically your pre-blood pump is essentially really almost it's your access pressure, right? Yeah. You see it's positive because it's coming off that little line. So you see that's controlled it. Your dialysate and replacement volumes are there. The replacement is post. Your patient fluid removal rate and your effluent. Now, if you look to the right, you'll see your access pressure is 93. Your filter pressure is 119. Your return pressure is 63, and your effluent pressure is 44. So when you have all of those in a positive range, in fact, that access pressure, like I said, normally is negative, but you can run it positive. 93 is an acceptable range. The return pressure is 63, and probably in a temporary dialysis catheter, it's going to be closer to 100, 150, but it's still positive. But that effluent pressure is positive.
Yeah, the whole thing's green there.
It's pushing the plasma water through the membrane, and that pump is simply controlling the rate, not allowing it to just free flow.
So that's how you protect your filter.
That's how you protect your filter, and that's how you prevent your deaeration chamber from emptying and potentially getting air in the line, which will shut the machine off. There is an air sensor, which it'll lock you out, and it's very difficult to get it out, so you're going to burn the set. Makes the set last much longer. In fact, I mean, I think that this way works and keeps it going for as long as you're using some kind of anticoagulation.
Yeah.
If you're not using anticoagulation at all, which sometimes happens, the filter's not going to last that long. It just isn't. But if you're using, you are anticoagulating it, you can. But the key here is, again, that you don't have a negative pressure pulling on the membrane and also pulling the deaeration chamber, and that effluent pump is not trying to fight against that negative pressure and just keeps pulling and pulling and pulling. And that's a lot of the reason why your filters fail. Now, I will also say that we can take those off now. I will also say thank you. I would also say that the one of the things I like about the PrismaFlex is it does have a software package that allows it to operate in a hostile environment where the other devices that exist at this point do not.
Meaning connected to ECMO.
Right, but it is defeated with stopcocks and turning them and doing that stuff.
Now that's on the new machine?
No, the next stage machine, for example, has historically had problems with alarming, but there are places that do a tremendous amount of ECMO and CRRT that use the next stage machine, and they use it effectively, and it is a good machine. It does work, but they defeat it with various different pressure dampening techniques.
So who has the software package?
The PrismaFlex, the Gambro, Baxter Gambro.
Okay.
Baxter Gambro. Okay, so I hope I explained it well. It was hard without arrows and stuff. I'll redo it, but did that shed any light on any of this, guys?
Yeah, it did for me.
Yeah, so it's interesting, Joe. You're definitely the expert on this, and I have some basic knowledge about it. But what we do, you just kind of touched on it. We use the NX machine.
That's next stage.
Next stage, and we hook it up different than what you've shown here. We hook it up both on the negative line. Inflow and outflow are about 6 inches or so apart. A 3/8 lure. We have it all set up already. We cut it into the line, and we basically have access and return on our negative line, which the downside is you have to be very careful about air, right? So we have a double check system where we make sure that doesn't happen. And so if you use the small restrictor line, that tiny 4-inch or 6-inch long restrictor line on your access to the CRT device, and restrict your negative, so you basically can reduce the negative that the CRT machine is seeing. You can almost reduce it down to next to nothing. Then your CRT device is happy, and then if you return it back, there won't be any mixing at all, because you're first going to take it on the way in and then return it back 6 inches down the line.
Yes.
You don't have any mixing. You just have to be very careful about your infiltration of air possibility.
Right. There's a million ways to skin a cat, and it's what works for you and what you're comfortable with. And I think that really my only lesson is not that I think my way is better or your way is better. I think both work very effectively. I think we got to think when we're integrating all of these systems into our system, and it's definitely a potentially a third rail, because in some of these systems that are being sold for ECMO right now, anything you do, you cut into the line in any way and add a connector. So you're using CardioHelp, it doesn't matter. You're using Tandem, it doesn't matter. You immediately void any protections you have from device failure because you have modified the device. And that becomes a legal issue, which I think we need to have somebody come and discuss that with us too, because I think that's product liability is a very big problem. And when you, as a clinician, go and do something that is technically off-label, which we do all the time, but you're modifying somebody else's device that was made for a reason to prevent what happened happening. No matter what happens or what the cause, the proximate cause was, that's going to get pointed to by a jury. And even if what you did had absolutely nothing to do with the failure of the device, you're going to have exposure, and that exposure is going to be potentially devastating. So I think that's my thought. We have to think outside the box. We live in a very dangerous world. In our business, it's a full contact sport, and we have to be very careful with what we do. But to make these things work and provide the optimal patient care when these patients are the absolute sickest, we have to, cautiously do things that we know carry inherent risk. But we have to be as careful as we can and avoid those pitfalls, avoid the landmines. That's what we do.
I haven't spent a whole lot of time thinking about the legal aspect, but what you just said gives me a massive headache. The legal aspect of it, I don't even think, I think we just have decided to put that on the back burner, because about 80% of the people or 85% of ECMO patients receive some CRRT in our institution, and the vast majority of them we cut into the line, like I said. And yeah, I didn't think about the modification of what could be implicated there, but I guess that's like you said, that's the game we're in.
Yep, yeah. We're in a tough sport.
Yes.
This is not for the faint of heart. That's for sure. It's why I mean, look at me. I'm only 30 years old. Look at what it's done to me, right?
Only 27, Joe.
Exactly. I know. You look great too. So can we take a short, let's say 2-minute, let's say 3 or 4 minute break if that's possible? I'd like to get another cup of coffee and maybe use the restroom. And put some new makeup on it. We're going to come back with John Ingram's Knowledge Nuggets.
All right.
And that's okay with everybody if you don't mind. Yeah. And David, is that okay with you? Yeah. Okay, so we'll take like a short, it's going to be quick, 3 to 4 minutes. Maybe if you all are out there, grab a cup of coffee yourselves, and we'll be right back.
Mixed cannulae, expanding performance standards. High-performance cannulae for direct and femoral cannulation in minimally invasive cardiac surgery. LivaNova's complete range of mixed dedicated products allow easy and reproducible procedures. The portfolio includes the sutureless aortic valve Percival, Memo 4D for mitral valve repair, the HeartLink system for assisting the perfusionist in applying goal-directed perfusion therapy, and a broad choice of high-performance dedicated cannulae. LivaNova's range of cannulae suit every cannulation technique for minimally invasive cardiac surgery. Venous and arterial femoral cannulation can be performed using the WRAP venous cannula and the EasyFlow Duo. For arterial, direct, and venous femoral cannulation, the EasyFlow aortic cannula and the WRAP are available. For venous femoral access, the LivaNova WRAP cannula features a dual-stage configuration for optimal drainage of the inferior and superior vena cava without interfering with the right atrium. The high-flow dynamics of WRAP improves the capability of drainage with a low pressure drop. An optional Sellinger dilator kit is available to perform percutaneous insertion. The LivaNova EasyFlow Duo cannula is designed for a safe and smooth femoral arterial cannulation. Its conical dispersion tip design allows a more gentle flow in the femoral artery, and its red cap avoids blood backflow during obturator removal. A dilator kit for percutaneous insertion is also included with the cannula. EasyFlow cannulae are designed for safe, reproducible, direct aortic cannulation and include a malleable stylet to aid cannulation insertion, facilitating bloodless introduction into the aortic arch, as well as a special conical dispersion tip for a more gentle flow in the vessel to reduce shear stress.
The point of care program at Huntsville Hospital is approaching its 20-year anniversary. As we began to grow as a hospital and provide more complex services to our community, the need for point of care testing became very clear in our organization. Many of our departments consider the EPOC device to be crucial to their ability to quickly move their patients from entry to the hospital to procedural room. It helps them monitor the patient's status during their procedures and post-procedure, so it's very integrated into our entire continuum of patient care. If you have any patient population where blood management is crucial, then a point of care device is very useful in those types of settings. It can provide a quick result on a very small amount of blood, and that is really important in some of our patient population.
We are starting a new process where we're going to screen our patients on the floor for sepsis. The patient can look and actually feel okay. They will show us signs and symptoms of sepsis. So what we do when they show these signs, we get a lactate level.
Lactic acid is a product of the sepsis cascade. So with sepsis, the inflammatory light switch goes on, the cascade starts churning, and unfortunately, once it starts going, we have to stop it. It will not stop on its own. The faster the lab draw, the faster the lab results, the faster you can act on it.
The process in the lab is what the process is. It just takes a certain amount of time for the instruments to run those tests.
I mean, we're talking 30 minutes even on a stat because that's the process. That's just how long it takes. There's not really anything you can do about that. For every hour you wait to give an antibiotic, the mortality for that patient increases 8%. So now that we have the handheld device, the nurse can get those results within a few minutes, and we know how to treat that patient. If a patient is going into septic shock, we do not have minutes to spare. We have got to get it done quickly. So when you get the little beep from the EPOC that says your results are in, you go with it. You don't even think twice about it. You're like, this is good. This is what I'm going to do for this patient. The next steps are clear.
I think our mortality on the initial floors dropped by almost 50% in the first 3 to 6 months. At this point, we're about hospital-wide. I think we'll be hospital-wide another 2 to 4 months. So this has become a huge program within our system.
Without the EPOC device, it would really be hard for us to get everything done in the timely manner. So it's really helped us to get our program going.
I mean, whether you're a surgeon, whether you're a medicine doctor, whether you're a dermatologist, you want to be able to do things in a timely fashion so that you can be most effective.
This really makes a difference in patient outcomes.
And welcome back, everybody. The next thing we're going to get is our introduction video for John Ingram right there.
It already ran.
It ran? Oh, okay.
And it was lovely.
That was a great introduction of John Ingram's Knowledge Nuggets. John Ingram, the floor is yours, kind sir.
All right, guys.
That's
Great.
brutal.
So we are on episode number 2 of John Ingram's Knowledge Nuggets. Today's February 10th, 2021. And of course, as always, with these presentations, I will have no disclosures with regard to the topic. And you know, our motto, our Knowledge Nuggets motto is spend a little time and expand your mind. And the reason we say that, I'm going to go over in a second. And this week's topic is the drug amiodarone. So the format is we have a different topic each week. Why do we call it Knowledge Nuggets? It's going to be something you can take home and be a better clinician tomorrow. When you see this shiny gold nugget up in the right corner of the slide, this is going to be a take-home slide. So people can figure out real easily when they're watching the lecture, this is something I can take a screenshot of, take a picture on my phone, and use it tomorrow at work. So it's just a 12 to 15 minute high impactful segment followed by a surprise gem of the week, a little bit of gem that we're going to throw in on every week. That's going to be a nice surprise, and then we'll have the panel discussion. And if anybody wants to email me with questions or comments or suggestions for a future show, there's the email address, john.ingram@perfweb.us. If you're watching the show live or in the future, email me, and I will respond to every person that sends me an email. Absolutely.
You know, John, I want to get more of these. We've got the Tammy Sparacino Journal Club Casino.
Yeah.
We've got the John Ingram Knowledge Nuggets. If you're watching this program, or if you're watching it and you know somebody else that would have an interest, forward it to them, and join us. We need more of this kind of thing to grow this community. We really do.
We want more segments, more hosts.
We want more segments, more hosts. We want, and John, of course, you have years and years of experience, and you have very contemporary experience in the trenches. We as well, Tammy more so than I at this point in time. But I'm the least capable of everybody, but at least I'm capable. But with that said, we need more of this. So please, John, I'm sorry for the interruption, sir.
Yeah, Joe, you make a good point. If there's anybody out there, maybe you're new, maybe you're shy, maybe you don't give a lot of presentations, I'm sure that any one of us three here will be able, be willing to help you out and get you started and help you get up and going with an idea that you have for the PerfWeb and Perfusion Education Program. So let's talk about amiodarone. It goes by two trade names, Nexterone, but I think Cordarone might be the more common one. But we're going to talk about it as if it's just called amiodarone. So what is the definition? What is it? It's a class 3 antiarrhythmic medication. We're going to talk about that, what that means a little bit further. You usually give it intravenous on an acute basis. If you have an acute problem, it's an IV medication, but it can be given long-term orally as a pill. But usually the therapy is short and acute, usually about 24 hours. It can go into 48 or 96 hours. And for longer term periods, like I said, you can do an oral administration, and people can actually take it at home, not just in the hospital. So for you chemical bugs, here's the chemical formula. Of course, it's an organic material with carbon 25, hydrogen 29, and 2 iodines, Joe and Tammy. And that's interesting. I'm going to point that out later. And then it has nitrogen and oxygen, three O2 oxygen molecules as well. So the clinical pharmacology, and this is where it really gets interesting. It's considered a class 3 antiarrhythmic drug, which means by large it's a potassium channel blocker, but it has the electrophysiologic characteristics, guys, of all 4 antiarrhythmic Williams class drugs. So that's what's very fascinating about this. And by the way, probably one of the reasons why this is so widely used. But like a class 1 antiarrhythmic drug, it's also a sodium channel blocker, which means it'll slow the rate and amplitude of initial depolarization. It reduces cell excitability and suppresses tachycardias, but it also reduces conduction velocity in non-nodal tissues, not affecting the nodal rates. That's the sodium channel blocker aspect of it. Like a class 2 antiarrhythmic, it exerts antisympathetic influences. It blocks irregular impulses that cause irregular beats, and therefore it's a negative inotrope and a negative chronotrope effects with the class 2 aspect. In the class 3, which it is considered a class 3 drug, it's largely a potassium channel blocker, and it therefore lengthens the cardiac action potential, reducing ventricular impulses, in particular ventricular tachycardia and BFib. But it also has a class 4 effect, which is it's somewhat of a calcium channel blocker. So it depresses calcium-dependent action potentials. It decreases the rate of automaticity. It slows conduction velocity, prolongs refractoriness or refractory period, and therefore it's a negative dromotrope. I don't know if too many people know what a dromotrope means. It means it slows the conduction through the node, through the SA node and through the AV node. And it actually has one more pharmacal characteristic, number 5. It also has some vasodilatory action, so therefore it decreases the cardiac workload and decreases myocardial oxygen consumption. So pretty fascinating pharmacology aspect to amiodarone. So what are its indications for use? So if you want to have a little bit of a knowledge nugget take-home slide, you can screenshot this for people listening. It's a treatment and prophylaxis for ventricular fibrillation, and it's also a treatment and prophylaxis for unstable ventricular tachycardia. Also for wide complex tachycardia. Now, you'll find this being used in your institutions very widely for atrial fibrillation and for paroxysmal supraventricular tachycardia, meaning tachycardia is based and originating from the atrium. This is off-label use. If you read the manufacturer's insert, it does not indicate this drug for atrial tachycardias and fibrillation, although you will see it in your institution widely used for this purpose. The dosage administration, it comes in 50 milligram per milliliter vials. The initial dose is usually mixed in of about 150 cc bag, and it's usually given between 150 and 300 milligrams over the initial first 10 minutes. And then it's slowed down to 1 milligram per minute for 6 hours. And then after 6 hours, it's slowed down to a half a milligram per minute over the next 18 hours. So you have a 24-hour acute attack there, acute window of treatment that usually is very highly effective. But you can modify this. You can increase the infusion rate as needed to suppress the arrhythmia. The drug is eliminated by the liver. But now before we go to the next slide, I want to ask you guys a question. Do you have any idea what the half-life of this drug might be?
No.
Any idea at all? Well, you know, like
can I guess?
heparin has a half-life. Go ahead, I'm sorry.
Can I guess?
Take a guess.
Well, based on how you
Dose it.
I'm gonna say the half-life is 4 to 6 hours. My
Okay,
guess.
go to the next slide. The half-life is 58 days.
Oh my gosh.
And that is
Closest
awesome.
without going over, John. Closest without going over. Price is right.
Price is
That's
right.
one over, yeah. So you win the prize.
No.
But this is amazing. When I saw this drug has a half-life of 58 days, and it can range in individuals between 15 and 142 days. When I researched this, I found out that people who discontinue the drug can come back as long as 8 or 9 months later, be seen by their doctor, and still see trace amounts of this drug in their system. Is that amazing?
Hey, I'm going to look on my app and see what that actually means. So go ahead, continue, because it is amazing.
Well, you have to realize the half-life means that half of the drug is eliminated in that period of time. So in 58 days, the concentration would be half. In another 58 days, the concentration would be 25% in your system. And in another 58 days, it would still be 12.5%. So you can look out 9 or 10 months and still see some circulating volume in your system. So the contraindications, though, is pretty important. It's another take-home golden nugget slide here, is that you obviously want to know if anybody's hypersensitive to any of the components in the drug. And that's true with any drug. But interesting in this one is that, remember when I showed you the chemical makeup, it showed it had 2 iodine molecules. Doesn't sound like a lot, but in the dry weight, and if you dry powder amiodarone, the dry weight volume of iodine makes up 37.3% of the actual weight of the drug. So you have to be cognizant if your patients are allergic to iodine, shellfish, things like that.
Oh.
You cannot give it in cardiogenic shock or patients with bradycardia. Patients with 2nd or 3rd degree AV block isn't contraindicated unless you have a pacemaker. Remember what I talked about earlier in the pharmacology is that this greatly slows down the patient's heart rate and conduction speed in 3 or 4 different modes. So if you already have someone who is in bradycardia or 3rd degree or 2nd degree block, you can cause complete asystole in patients with amiodarone. And by the way, someone who's in cardiogenic shock and in coding, you do not give them amiodarone because it's going to decrease their ability to conduct and to contract.
So
Go
John,
ahead, Joe.
just for
Yeah.
the record, there is, of course, 58 days, 50% remaining, but just for reference, you still have 3.13% remaining after 290 days.
Mm-hmm.
So if it's 58 days is the median, and it could be higher, could be a little lower, but it could be higher.
Right.
You could have this stuff in your system for over a year.
Correct.
And can I ask you a question real quick before you go on to the next slides? So I noticed that cardiogenic shock. It says you decrease myocardial O2 consumption, which makes sense to me, of course, if you take the arrhythmias away. But if it's a negative inotrope, is there any that you shouldn't use this for somebody that's in, let's say, heart failure? They're in heart failure and they're having arrhythmias. Is there a contraindication there?
Yeah, you have to be careful because if you're having a poor contractility, remember it's a calcium channel blocker. It's a sodium channel blocker. If you have poor contractility, you very well may decrease your ability to contract. So you probably should look to some of your other antiarrhythmics. In fact, we're going to talk a little bit about that here in a second, Joe. That's a good question. So another little nugget slide. Adverse reactions with this drug are pretty profound. It's pretty common to see people, when you give them amiodarone, that they get hypertensive. And they slow their heart rate, and you can go overshoot that very easily and get somebody into bradycardia and even asystole, resulting in cardiac arrest. You can sometimes see pulseless electrical activity. And an interesting one, too, is that you're trying to treat this, difficult VTAC or VFib, and you can actually have a paradoxic response where this drug can actually cause arrhythmic problems, especially VTAC, the very thing you're trying to treat. That's unusual. And then, of course, you don't want to give it to somebody in cardiogenic shock because it can cause it even worse, right? So here's some other acute adverse reactions, not as common. It can cause torsades. For anybody who doesn't know what torsades is, it's a polymorphic version of ventricular tachycardia. And Joe, we can do an actual segment on torsades one day because it's an involved, interesting electrical phenomenon. You can cause somebody to go further into congestive heart failure, and it also can have toxic liver effects. And you can see people, you have to test their liver function tests from time to time and see if you're causing some liver toxicity with this. So now here's a chart that I got off the manufacturer's insert. And basically they show you the incidence here of the side effects and complications that happen. And they're pretty significant. In the left column is just the event. You can have fever, bradycardia, congestive heart failure, all the way down. But if you look at the second column, these are the actual controlled studies that were done for the treatment of VTAC or VFib. If you look to the right where it says off-label studies, these are a lot of the studies that have been done outside universities and individuals that did studies, and they include patients in atrial tachycardia and atrial fibrillation, which is an off-label use for it. But it's interesting to see the complications and adverse reactions that both of these types of studies found. So if you look at the two I highlighted in yellow, which I mentioned before, common ones is bradycardia at 6%, and hypertension you've seen in 20% of the patients. And if you add up all the other ones there, you come up with about a 45% incidence of side effects or complications with the actual controlled studies that were done. And some of the off-label studies found something pretty similar. They also saw a 4% bradycardia rate, 12% hypertension, and about a 32% total complication rate with this drug. So if you actually combine the two together there at the end, on the bottom, you have about a 37.5% incidence of acute complications and adverse effects with this drug you have to watch out for, especially with bradycardia and hypertension. So now, with those two, hypertension and bradycardia, when you see it, what do you do about it? This is some of the interventions. You need to start slowing the infusion rate of the amiodarone. You may need to compensate with some vasopressor drugs like positive inotropes and volume. Volume, of course, because of that vasodilatory effect that you can have. If you're seeing bradycardia and some AV block, you also need to slow the infusion rate. You may need to discontinue the infusion rate of the amiodarone if you see these two happen frequently. So kind of highlighted those. So now I call this non-acute complications because they are long-term, but some of them can happen just in a matter of a few days or weeks. And this is really the big ones here, guys, is you can have something called pulmonary toxicity. We've seen this actually at our institution where people develop a very strange pulmonary infiltrates and masses appear on x-ray. They have bronchospasm, seeing cough, hemoptysis, even respiratory failure, and you don't know the cause, and the only thing we can point it to is the dosing of amiodarone. It can lead into ARDS, but pulmonary fibrosis is one that you see occasionally on people that go home on it and are on it for a long term, months or even years, that can develop a very severe form of pulmonary fibrosis, which, by the way, is fibrotic, and so
Yes.
it's not something you can treat.
It's
you
not
can see loss
recoverable.
of vision. There's thyroid problems, hyperthyroidism, hypo, and even thyrotoxicosis. You can see electrolyte abnormalities, hypokalemia, and hypomagnesemia. Occasionally you see. So now here's a conclusion. It's a nice take-home slide for people watching. Gives you a snapshot of what I've just discussed. Amiodarone is a class 3 antiarrhythmic medication that possesses significant attributes of all 4 Williams classes of antiarrhythmics. Amiodarone should be reserved for patients with unstable and refractory ventricular tachycardia and fibrillation, but is often used off-label in cases of atrial tachycardia and atrial fibrillation, but not without controversy. Amiodarone is wrought with adverse reactions and complications, and patients need to be monitored closely for intensifying hypertension and bradycardia. Now we're going to go real quick into our gem of the week, this week's gem of the week. So, you know, the gem of the week is a surprise. It could be a perfusion trivia question we might pose. It could be how to do tips on interviewing, especially virtual interviewing. Could be about a career opportunity or a great job offer, something we covered last week. It could be something in the news, like a perfusion device recall. You never know if we could put one of those in there. It could be something happening in Perfusion Week, like when we honored Terry Crane not long ago for over 50 years of his remarkable perfusion service. I could just put in an interesting quote one week that we may talk about and how it could be used in our lives. Or we could feature an upcoming nice perfusion conference, such as the New Orleans conference that you throw from time to time. But this week's episode, Gem of the Week, is going to be a perfusion safety tip, okay? And this is a perfusion safety tip sanctioned by the Perfusion Safety Committee of AMSEC. Okay, it is not something I just made up. You can go there and see this and find this for yourself, print it out and use it. Okay, go ahead. And what is it exactly? Well, or why is it? Why are we covering the perfusion safety tip? Perfusion safety is avoidance of a preventable incident that results or may result in an adverse patient outcome. So there are 4 categories of perfusion safety. Number 1, most common, human error. Number 2, most common, communication failure between colleagues. Number 3, the failure to anticipate an adverse event. And even though it's talked about seemingly more than anything else, malfunctioning equipment and supplies is actually the lowest of those 4. So we're going to talk about handing off your case to a colleague. A lot of people work shift work where they get relieved at a certain hour of the day, or maybe at a certain hour of the day the call person takes over at your institution and takes over for you or on your case. So this is what we're going to talk about. It's called the I Pass the Clamp Off checklist. Okay, it's an acronym. I Pass the Clamp Off checklist. Okay. And what it is you look down the left there, it's going to give you the I pass the clamp off acronym, okay? And the first one being I, so when you have this, now you can go and you can print this out off of AMSEC's website and use it, or you can modify this a little bit shorter version to suit you at your institution, because this is actually pretty thorough and a little bit extensive. You might want to shorten that. And so the first one being that you should inform the person taking over your case, is the person on any isolation or on any precautions? The P is, what is the procedure? We're currently doing a CABG, then an AVR procedure. The next thing you should do is inform the person taking over, what is the age or what are the allergies of the person? The person is allergic to latex, maybe they're allergic to iodine, as I just mentioned. Okay, maybe they're a 57-year-old or an 82-year-old. The next thing you might want to go through is, where are we on the procedure? We're tying down on the mammary. We're just now opening the chest. Maybe we're doing the second proximal, that type of thing. The next thing would be, where are we in our cooling and rewarming? We're sitting at 28 degrees, or we're already in the process of rewarming, or we're cooling and we need to target 30 degrees, that type of thing. The next thing might be, what is happening with the blood products in the room? Do we have blood in the room? Did we give blood to the patient already on pump? What about the history of the patient? The patient might be had an AVR procedure 5 years ago. It's a redo operation. Maybe the patient's diabetic. What is the status of our equipment? In other words, we have a 3/8 venous line because we have a small patient. Maybe we have a small adult oxygenator in line. Is all the equipment function normal? The circuit information, same thing I was just saying. Is our arterial line stopcock open or closed? Right? That type of thing. L, the lab values. You know, what is our potassium level? What is our hematocrit? What's our target hematocrit during the case? A, for anticoagulation. What has our ACTs been running? What is our heparin dose? Is the patient resistant? Medications would be M. Are you infusing mannitol? Is mannitol dripping into the pump right now? Are you on 1% or 2% fluorane on your gas? What about the P? The P would be the pump settings. You know, are your alarms set? Are you off pump but your RPMs are running at 2,000 but you have a clamp on the line? What are some of the things about your pump settings? What is the O? Any other concerns? It's just sort of a catch-all. Other concerns or conditions you might have had that have come up. The F would be fluid status. You know, did you prime with a lot, or did you take off any prime? Did you wrap? Has the anesthesiologist given 2 liters before we went on pump? Did you do a pre-donation bag? Any final thoughts and comments? Anything else you want to include in there? Like, for example, who's your backup perfusionist? Who's the first call person you would call who is available in case you get into trouble or have an issue? And that would be a nice safety to pass off your case to somebody else taking over. And I kind of laugh at this, guys, because when I had my first job, I had worked with 2 guys who'd been around for a very, very long time, worked together for decades. And I remember hearing them one time when they would relieve each other for lunch, and then the guy would come back to his case because they would relieve each other for lunch. The one guy would say, everything you had clamped, I have unclamped. Everything you had stopcock, you had open, I have closed. That's what he would say, because these 2 guys were like a 2 old married couple. And I just thought it was kind of a funny thing that they would go on. So let's go on to our next, I think we're ready for. So why did I cover this? You know, there was a lot of work done by the great Mark Cruz, because he pioneered safety studies. I don't know how many he did in the 80s and 90s. And he has a quote in this particular article in 1988 that he did called Perfusion Safety. And he says, in closing, the basic issue of perfusion safety is the attitude of the people. And what should be evident is that perfusion safety is highly dependent on the human factor, both in producing errors and accidents and in preventing them. So I think we are now, if you guys want to email me again questions or suggestions for a future topic, any comments, please email me at that email address on the screen you see there. I will answer every person that emails me. And I think we're probably ready for our panel discussion. Amiodarone and handing your case off to a colleague.
Very good. Excellent,
Excellent.
John. Very, very, very good.
I loved it.
Well, I mostly loved it.
Oh, don't even get me
I
started.
mostly loved it.
I loved what you mostly didn't love. And in fact, I think I do this entire checklist. So it's lengthy, but I think I do this already. I was not familiar with the acronym, but
That's very. I mean, it's
It's
leave
good.
it, leave
You know
it,
what's,
leave it.
what's interesting is that I've been 100 places. You guys have been 100 places. I've never seen anybody actually use this particular list, but this is something that apparently has been up on our AMSEC website for quite some time, but I've never actually seen anybody do this exact list. Have you?
no, not this exact list, but I think I probably covered just about all of these things in my handoff, even when we're doing handoff for, ECMO. But yeah, I thought it was great.
Okay, so leave it to AMSEC to make a list that is longer than your piece of paper.
It's not longer than my piece of paper, and it's a cute acronym that I can remember.
That's number
Well,
one.
I think what Joe, I think what they had in mind is by the time you get done with the checklist, you're already off pump, so you don't have to hand the case off to the person anymore.
So let me ask you a question. It's very easy, it's a simple question.
Okay.
I can make a checklist that covers all of that in one very short sentence.
Don't get relieved by someone else in the middle of a case.
Yeah. Yeah, there you go. Don't. And maybe this just happens. I understand that people do shift work. I had to work on that. Okay, I paused. There's a pause.
There was a pause.
Do shift work. I do understand that. But I have a fundamental disagreement with this whole concept of starting a case and then getting relieved at whatever point it is in that procedure. I've always felt that there's a breakdown in continuity of care to the patient. I don't like relieving people in the middle of procedures because I don't have a feel for what's been going on. I can go through that whole long list and all of that, and I think there are times, and this is just my belief, so I mean, you take it for whatever it's worth. I know people will disagree with me, and I accept that, and that's fine. I just am very uncomfortable with that, either taking over or being relieved, because I feel that I know this patient from the minute I got there, or I don't know this patient at all, and I really don't know how this whole case has been going. That acronym, though, is good for safety. I'm not going to dispute that it's very good for safety. It's very comprehensive. I do agree with that. But, is it realistic? I don't know. I think it's going to be, I think some people can do that. I think some people can't. And I just fundamentally disagree with shift work.
Well, but let's take it beyond shift work, if you don't mind. Sometimes you are going to get relieved.
But that's those are unique circumstances, and I think that in those cases, you're sick, somebody in your family needs your help. There's some kind of emergency that occurs. But I mean, I think shift work exists especially the big medical centers. It's very common. I do recognize that it is the way our practices in some places are structured, and I certainly do respect it. I do understand it. It just isn't for me. But with that said, I will swallow my pride and say that I do think that there is inherent value in that list, and I think it's very good, but I think it gives everyone pause as opposed to, here's the clamp, everything's good, we're warming, no problems, talk to you later, bye. I think
that's how most people hand off the case.
Yes.
Most people hand off the case in about 20 seconds. While I'm getting out of my chair, you're getting into it, and I'm like, yeah, we're rewarming, and two things, and you're out the door. And 99% of the time, probably it does work out okay. But You know, we talked about we had a perf web program, remember, Joe, where it had to do with they exsanguinated the patient when they
Yes.
Yes.
when they, you know, and that happened to me one time, and it happened on a pass off. I passed the case off to somebody else.
I remember you told that story. Now, the one I talked about was not a handoff.
I know, yeah.
That was
I know.
that was.
But it could have been from something that could have happened from a handoff.
Yes, well, it has. I know of. Well, John, you know your case.
Yeah.
In your case, your patient survived. I wasn't involved in the case, but I know it very well. It was a handoff, and they thought they were off pump, but the cannula was still in, and the recirc line was inadvertently left open, and of course the patient was exsanguinated, and died.
Well,
But
we don't even have to go to those extremes.
I'm on red, Magic.
So, not to interrupt you, Tammy, real quick, but Joe,
fine.
anywhere that the perfusionists work for the hospital, they almost always work shift work.
Correct.
And there's a lot of places out there, some major medical universities. A lot of times they're not contract, they're salary staff or hourly, and they don't want to pay overtime. So at 2 o'clock or 3 o'clock, you get relieved on your case.
That's right.
And it happens many times a day somewhere in the country. I think with this list, it gives you a good idea. You probably could shorten it by at least 2/3 and probably make your life a little bit easier.
Mm-hmm.
But it's still a comprehensive. It gives people an idea.
Well,
Yeah, I think gives them pause. I'm sorry, forgive me.
No, it's
Go
okay.
ahead.
I was just going to say, but we all do shift work if we do ECMO. That is shift work.
Yes, well, yes.
And
I
you don't
do-
necessarily know the patient.
Mhm.
Sometimes we have multiple patients, and you might not make the rounds through a particular one, but then, scheduling needs change, or it's your
Sure.
turn to be on call for the weekend, and now
That's
you're going to have a
fair.
new patient, and so you are doing shift work.
That's fair.
And although a lot of times it may not be moving quite as quickly as a surgery case, there are things going on that you need to be aware of.
Mm-hmm.
One day, one of our people came in and we're like, hey, we're not on heparin anymore. Can you imagine if you had come into that and hadn't been told that, and that's not a part of our regular practice?
Mm-hmm.
So there are things that need to be communicated. They may not be these exact things,
Yes.
but I'm a big advocate for making sure that there is time for a handoff.
I totally agree with you 100%. I do think that we have to do on ECMO patients, we need to do a comprehensive report. I think for heart patients that are, and of course, perfusion in the operating room and the dynamics associated with that are so different than ECMO in the critical care unit. They're even though they're both extracorporeal circulation, they're two totally different animals. And the information that you need is totally different on both of those fronts. However, I fundamentally agree with you 100% that if you are going to be taking over for whatever the reason may be, unless it's a life and death circumstance, and you just have to do what you have to do. That happens sometimes. That can happen. We're all human, and things happen to us. But I do agree that there should be a very comprehensive report on every patient, and should be required by the receiving person before the current responsible person is then cleared to leave.
Right.
And I think it's the receiving person's practitioner's responsibility to say, slow it down, I need to know what's going on. We do need to build that into our practice. I agree. I agree 100%. John, you're talking to Emerald was great, by the way, but I have one other complaint, and I do love your knowledge nuggets, and I love your gem of the week. However, you highlighted as just part of your routine a job in Kansas City, and I'm hiring. You could have used us. Okay,
there's no phone number to call. There's no phone number to call. That's not a job. That's an old poster I found online.
Okay, you will use our new poster, John. Our new poster.
Send me one, I guess.
John, David will send that to you. You have it. You have our brochure. You can get it off het.us. Click down. PDF, put it on there. You could just highlight HET because
Because,
we need perfusionists too. I don't need people calling Wichita looking for a job because they'll probably hire them. I need them to call me.
Well, you seem so agreeable.
Very. I saw that come up, and I was almost like, cut the feed. Just cut it. Cut John out. That's it. So anyway, but no, I do think that these are important topics. And I want to get back to doing more of those legal cases. I'll ask you this, and Tammy, you may know the answer. John, you may know the answer as well. Folks out there, do you know what happens to a perfusionist when they are sued for malpractice at any time in their career? What does that moment that they are sued for malpractice delineate for them as practicing perfusionists?
I'm sure they don't get to practice again.
Well, it's not that they don't get to practice
They
again.
can't get insurance.
No, they can get insurance.
No, if you just get served, you know, you've just been
sued
served.
and
The outcome,
actually
you don't
sued.
know the outcome yet.
Especially if it was a truly adverse outcome, a major
Well, right.
stroke or death.
Oh, of course, it depends on the outcome.
Right.
Right.
But,
of course.
you know, it's the last case that they ever do. It is the end of their career. Not because they're not allowed to work, not because they can't get insurance, not because somebody else wouldn't hire them. They simply cannot handle
the stress,
what has happened.
PTSD from it.
Well, the overwhelming sense of guilt, especially if it was an avoidable problem, that when a perfusionist is sued and is essentially the plaintiff wins that case against them, even if they were only part of a group, that they weren't necessarily the proximate cause of the patient's death. Just having been sued and found responsible, which happens about 90% of the time.
Really?
When a perfusionist is, yes, you get sued along with everybody else.
Yeah.
And the insurance companies will simply settle the matter, which even though you're not admitting guilt, it feels that way.
Yeah.
But that is the moment that occurs, almost always, not 100%, but really close to it, delineates the end of that person's practicing career, which is tragic in my view. Unless what they did was malfeasant or what they did was truly negligent. But, you know, that's what we said from the very beginning. We're in a rough sport. And, you know, we're human and we can make mistakes. I certainly, I've talked about it before. I give a program on it. You know, I know 4 times that it was only by sheer luck that there was no adverse outcome. But I mean, I was, you know, been doing this a long time, and you know, I've messed up.
Yeah.
And it's very scary.
It is.
When you get that close. I've just been very lucky. Oh, by the grace of God, go we, or go I and we. Anyway, John, great talk. Enjoyed the heck out of it.
Thank you.
But I just really have to ask you that I just need your gems to always, until we get back up to full staffing, we need to focus on HET's job, gem of the week.
Should I put that as a repeat every week for a while?
In perpetuity until notified otherwise. Tammy, any closing remarks?
No.
Questions about amiodarone? I think we use it a lot.
We do. But it really should be a last resort, right? Look at
Well,
all
that's
those.
what it sounded like to me.
Look at all those adverse reactions and how long it sticks around.
I didn't throw that in, but Tammy, you're seeing amiodarone as the very first sign used as the very minute that somebody in the unit has a little hiccup. Amiodarone. In fact, people just call it amio now. They don't even say amiodarone.
We don't even say the whole name anymore.
Yeah.
And really, it's really supposed to be used after you've tried 1 or 2 other things and it's not working, and you still have a pesky VTAC or occasional VFib. You've got to go to amiodarone. It's actually flipped around. I mean, it's a very, very widely used drug. I hear it almost daily when I'm walking around the unit, or I don't know about the OR so much, but you guys see it a lot?
We use it in the OR.
Yeah.
We use it a lot. But I mean, so should it be lidocaine magnesium? Should it be
But I think when
is that
I
the thing?
see it, I lidocaine's first, then the magnesium, then maybe more lidocaine, and then amiodarone. And even then, sometimes some of our surgeons are like, hold off, let's see, wait a minute, take a breath.
Yeah.
So I think some people are.
Potassium, check the potassium.
Right.
There's a lot of things you can
Yeah.
check, that you need. But a magnesium, big one. I mean, hypomagnesemia, a low magnesium is problematic
Well, and I don't think we.
from an electrophysiology
I don't.
perspective.
I always try to know the starting way, and
Mm-hmm.
if it's low prior to going on pump, you need to treat it then,
Yes.
and then probably still give some more after the clamp
And
comes
that
off.
brings up a very good point. Guess what is not in now? That you can get it now, but you have to special order it, request it. Guess what electrolyte is not in, or ion is not in CRRT replacement fluid?
Is that it? Magnesium?
Magnesium?
No.
Oh.
No, it's phosphorus. I forgot. I thought it was magnesium, but I had to think about it. And I went,
Oh.
no, never mind.
Oh, never mind.
I
That's
pulled
just
that question back.
That's just a side note.
Yeah, side
Well,
note.
if
But
you-
you know what?
if
If we
you
do,
get-
if we do ultrafiltration, zero balance ultrafiltration in the OR, and we use saline to replace, we are going to dilute the magnesium down.
Yes, we will.
Yep. So that's something else to think about. What I do is just yell, give Bertilium, and they always tell me that that's not on the market anymore. That
Right, they
doesn't
took that
exist.
off, yeah.
Yeah, but I watch ET, and that's what they gave him, Bertilium,
Yeah.
when ET went into VTAC.
Oh, I need to rewatch that.
So I just ask for Bertilium all the time, and they're like, they don't make that anymore.
Yeah. Well, you know what? That was the you said, Tim, you said lidocaine then potassium. It used to be lidocaine then beryllium. That was,
Yeah.
they're always
But
in the code.
lidocaine,
That's what it is.
magnesium, potassium if it's low, and then more lidocaine, and then maybe amiodarone.
Yeah, I think that's how I see it.
Yeah.
But
Yeah.
I mean, low potassium, you're probably going to know in advance that this is a person that has low potassium. Because with giving cardioplegia, we
Yeah.
usually keep the potassium, normal or on the high side. So you should already be anticipating this patient came in with a 3 potassium to start, that they probably run low.
They may just be hypokalemic people.
Yeah, they just
Right?
might be.
Just happens. Or
Yeah.
they
Take a lot of diuretics or,
right.
you know.
Or insulin
Yeah,
and drive it into the cell. That's going to come back out, but that's going to be later.
yeah.
So I guess anything can happen. John, thank you.
We have an upcoming knowledge
Yes.
nuggets. It is going to be magnesium. Is that the next
There
time?
you
or
go.
not?
Wow.
And I almost said it wasn't in CRRT fluid, but it is. It's the phosphorus that's not in it. But
I'm
now
not-
you can get phosphorus in it.
Yeah.
Yes, so February 25th, that's the 25th of this month, Tammy Sparacino,
Journal Club.
Journal Club Casino
Well, that.
It rhymes.
is going to be myocardial protection is a process, not an event, and updates on myocardial protection. And then John Ingram Knowledge Nuggets it says antifibrinolytics, John.
Well, but there's one coming up that's magnesium.
Oh, yeah.
Not the very next one, but it's
No,
coming
man,
up.
that's a long way out, dude.
You want
That's
me to
all the
switch
way.
it?
That's April 7th. Yeah, if you want to switch it, just switch it.
Well, you guys already have your promotions and advertising up on.
That's
on
okay. I
social
can
media.
change it.
Oh, it's fine. It's only
It
a,
don't
it's,
matter to me.
it's, it's
Don't
less
matter
than
to
2
me.
months.
No, I can change it. That's not a problem. Also, just for reference, today's program was approved for 2.2 Category 1 CEU by the ABCP, and next week's program is also 2.2, not next week, on the 25th, 2.2 Category 1 CEU by the ABCP. So thank you all very much.
Thank you.
John, thank you as always. This is great. I love your new studio. It's beautiful. It looks truly academic.
Well, that's why we have knowledge nuggets. You need to make it look like we had some knowledge behind us.
Most excellent. Thank you all very much. Good afternoon. Good day to y'all. Good evening to y'all. I'm gonna get some sleep, and I have to go back to work tonight. So y'all take care of yourselves. Bye.
Bye.
Take care, guys.
Mixed cannulae, expanding performance standards. High performance cannulae for direct and femoral cannulation in minimally invasive cardiac surgery. LivaNova's complete range of mixed dedicated products allow easy and reproducible procedures. The portfolio includes the sutureless aortic valve Percival, Memo 4D for mitral valve repair, the HeartLink system for assisting the perfusionist in applying goal-directed perfusion therapy, and a broad choice of high-performance dedicated cannulae. LivaNova's range of cannulae suit every cannulation technique for minimally invasive cardiac surgery. Venous and arterial femoral cannulation can be performed using the WRAP venous cannula and the EasyFlow Duo. For arterial direct and venous femoral cannulation, the EasyFlow aortic cannula and the WRAP are available. For venous femoral access, the LivaNova WRAP cannula features a dual-stage configuration for optimal drainage of the inferior and superior vena cava without interfering with the right atrium. The high-flow dynamics of WRAP improves the capability of drainage with a low pressure drop. An optional Sellinger dilator kit is available to perform percutaneous insertion. The LivaNova EasyFlow Duo cannula is designed for a safe and smooth femoral arterial cannulation. Its conical dispersion tip design allows a more gentle flow in the femoral artery, and its red cap avoids blood backflow during obturator removal. A dilator kit for percutaneous insertion is also included with the cannula. EasyFlow cannulae are designed for safe, reproducible, direct aortic cannulation and include a malleable stylet to aid cannulation insertion, facilitating bloodless introduction into the aortic arch, as well as a special conical dispersion tip for a more gentle flow in the vessel to reduce shear stress.
The point-of-care program at Huntsville Hospital is approaching its 20-year anniversary. As we began to grow as a hospital and provide more complex services to our community, the need for point-of-care testing became very clear in our organization. Many of our departments consider the EPOC device to be crucial to their ability to quickly move their patients from entry to the hospital to procedural room. It helps them monitor the patient's status during their procedures and post-procedure, so it's very integrated into our entire continuum of patient care. If you have any patient population where blood management is crucial, then a point-of-care device is very useful in those types of settings. It can provide a quick result on a very small amount of blood, and that is really important in some of our patient population.
We are starting a new process where we're going to screen our patients on the floor for sepsis. The patient can look and actually feel okay. They will show us signs and symptoms of sepsis. So what we do when they show these signs, we get a lactate level.
Lactic acid is a product of the sepsis cascade. So with sepsis, the inflammatory light switch goes on, the cascade starts churning, and unfortunately, once it starts going, we have to stop it. It will not stop on its own. The faster the lab draw, the faster the lab results, the faster you can act on it.
The process in the lab is what the process is. It just takes a certain amount of time for the instruments to run those tests.
I mean, we're talking 30 minutes even on a stat because that's the process. That's just how long it takes. There's not really anything you can do about that. For every hour you wait to give an antibiotic, the mortality for that patient increases 8%. So now that we have the handheld device, the nurse can get those results within a few minutes, and we know how to treat that patient. If a patient is going into septic shock, we do not have minutes to spare. We have got to get it done quickly. So when you get the little beep from the EPOC that says your results are in, you go with it. You don't even think twice about it. You're like, this is good. This is what I'm going to do for this patient. The next steps are clear.
I think our mortality on the initial floors dropped by almost 50% in the first 3 to 6 months. At this point, we're about hospital-wide. I think we'll be hospital-wide another 2 to 4 months. So this has become a huge program within our system.
Without the EPOC device, it would really be hard for us to get everything done in the timely manner. So it's really helped us to get our program going.
I mean, whether you're a surgeon, whether you're a medicine doctor, whether you're a dermatologist, you want to be able to do things in a timely fashion so that you can be most effective.
This really makes a difference in patient outcomes.